Good morning, good noon. Well, I guess it is afternoon. Good evening, everybody. Thank you so much for joining us. Happy Thursday. We're very, very excited for today for many reasons. We were just chatting behind the scenes that it's becoming rarer and rarer that everybody in the lukewarm seat is a CP Solvers team member, in large part because we've been so excited to welcome so many people from the case review committee who hopefully all of you will become eventual CP Solvers team members. But we're thrilled today to share the stage with Yaz and Laura. And I will pontificate about both of them. I first met Laura many, many, many moons ago. As part of VMR. And I don't think that there is a proportional representation of what Laura has done because so far, so much of it is behind the scenes, culminating most recently in a very public and not so behind the scenes, outstanding CP Solvers blog post, which you should totally check out. It's called Reasoning Rendezvous. It's the second post on there, and it's absolutely it's quite the read. I don't want to spoil it for anybody. But more importantly, Laura's everywhere. She's in the emails and the infographics and the social media team on VMR, and just as silently building mountains of impact behind her. And truly, this is just the beginning. It really, really just is. She's still hasn't even graduated yet. So cool to see that you've had so much impact at such an early stage. And it's so cool that you're coming full circle because this is the place that I first met you. And I remember an RLR case presentation many, many moons ago. And before I pass the mic to Laura to say hi for her case, I get to discuss with my friend, truly, I can say friend, and basically family member. Ironically, as soon as I said that, my mom just opened the door from her time on a walk. Um, um, I also met Yaz many, many, many moons ago, and I think all of you are very, very familiar with her impact here in the virtual morning report. Um, I've gotten closer and closer to Yaz because, as she'll tell you, we've been working more one-on-one on her leadership. And yes, she's not even a resident yet, and she's leading so many things, including being one of the leaders for VMR, being a leader for the IMG project, and more importantly and more recently, making so much impact mentoring many people in the CP Solvers Academy. So I've got to hang out with Yaz a lot in that space and only started to appreciate the tremendous impact she's having in the world of research, including mentoring people on writing research related stuff with Saman and Maria. So it's crazy. This is just me pontificating off the top of my head. We have two extraordinary people here today. And very, very excited to share the stage with you both. I'll pass the mic to Yaz first to say hello, and then to our case presenter, Laura, and we'll kick it right off.
Yeah, thank you so much, Ravi. Honestly, that you're all very kind with me, and I am very happy to be able to grow with all of you. As you may know, I really like plants. So for me, seeing like investing this time in people and individuals and their growth, for me, it's like seeing like my avocado plants grow, or like, I really think that's something that gives me a lot of pride to be able to contribute to this space. And honestly, something that I should note this year is that CP Solvers Time grows so much and from so many places. I am super happy.
Hi everyone. I want to say that every time, like I'm not often here, like actually saying out loud things, but every time that I am, Robbie just says a lot of beautiful words, and I blush, and I feel like he really likes, like he enjoys seeing me like be really shy about just being here. But I'm very happy. I love this family. I love working with you guys. I was thinking it's almost like 3 years since the first time here, so it's been a long time, and I'm as excited as ever. And I'm super excited for today's case and to watch Rabih and Yas discuss. And I think I'm gonna start. So the first aliquot, it's gonna be 6 aliquots, okay? So the chief complaint is unresponsiveness.
Yeah, as we're in the deep end, the patient is not responsive. I'm really curious. What do you think you
I'm
might be doing in that point?
I'm thinking like this is like just to be in the same channel, like alter mental status. We're thinking about this, right? Because when I'm thinking on responsiveness, I'm thinking, where did this patient come from? Like I'm situating myself in front of this patient in
Yeah,
the ER and seeing an unresponsive patient. First of all, is perform your ABCDE survey. Keep them um, how to say, like check glucose, check glucose score. Try to prioritize every single red flag that you may look around. Reversible causes are the first. When I am looking at a responsive patient, I'm situating myself in the ER and I'm thinking, check oxygen, put ventilation, look for um, shock, like look for shock in the patient, hypoglycemia, and then another thing that's very important, and sometimes we don't really think about it, is if this patient has in his vital signs any sign of opioid overdose or any other kind of like exposure that we can rapidly reverse. Um, so that will be in summary. Unresponsive patient, ABCDE survey, address rapidly reversive causes, and initiate protective measures.
I
That will
couldn't
be my first three things.
I couldn't agree more with you. And I think that as you try to visualize the circumstance, I think you're often visualizing something else that can tell you why the patient's unresponsive. So yeah, as I think the most important thing is this patient perfusing? Because unresponsiveness could mean that this patient actually is code blue and has no perfusion whatsoever. And so I think that that's the priority is the patient breathing? And I think you probably would not call something unresponsive if you actually had apnea or the patient's not breathing at all. So I think the very fact that we're saying this patient's unresponsive and not saying something a little bit more serious like apnea makes it much more likely that the patient is breathing. And if the patient's breathing, it's much more likely that they have a pulse. But whenever you hear this word unresponsive, either the patient has severe neurologic catastrophe or the patient has a severe cardiovascular catastrophe. And the cardiovascular catastrophe is our first priority to make sure that the patient is perfusing. The difference between a neurologic catastrophe and a cardiovascular catastrophe is often inferred by the presence of spontaneous breathing or not. So my first question or first observation would be, is this patient breathing? And if they're breathing, they're likely perfusing. If they're not breathing, then it's probably a code blue. What do you, yeah, I'll pass the mic to you, Lara. Tell us more.
I'm already having so much fun. Okay, that was amazing. And I'll give you more information now for the HPI. It is a 63-year-old male, and he was brought in via EMS after he was found down in the street by bystanders. The history was limited due to increased agitation exhibited by the patient during the exam. And he was awake and verbal on arrival and reported bilateral knee pain and heavy use of fentanyl and alcohol prior to presentation. Otherwise, he wasn't able to recall anything else. His mental status continued to wax and wane, and the patient was noted to have O2 desaturations to 85%, requiring BiPAP. For the past medical history, he had COPD, but not on O2, hypertension, polysubstance use disorder, alcohol use disorder, anxiety, and major depressive disorder. And for the social history, he was homeless and had an unknown history of smoking history and history of heroin use. There was a history of fall and right frontal skull fracture and right orbital fracture. He was allergic to NSAIDs and for medications. Albuterol inhaler, Incruse inhaler, amlodipine, lisinopril, paroxetine, gabapentin, folic acid, thiamine, ferrous sulfate, and magnesium oxide. And that's the end of the second aliquot.
I just wanted to say real quick, Laura, you're a pro at presenting this and equally matched by Shreyas, who is somehow keeping up with the ferocious, acute information you're giving.
I sent him the case.
Oh, we caught on you, Shreyas. Can I just ask, Laura, is the patient unresponsive now, or just to help understand, or was he unresponsive initially and then became more responsive? Is that right?
Yeah, I believe he wasn't responsive, but when he arrived, he was awake. But his mental status, like he was confused when he arrived.
I see. And just one more question. Was there any intervention that resulted in the change from unresponsive to responsiveness, or he just kind of with provocation and other people stimulating him woke up? No intervention.
Yeah, I believe there was no stimulation. Like there was no intervention.
Gotcha. No pharmacological intervention. Okay, terrific. Yes, I'm curious. What would you summarize the problem before you now? What is your mind trying to fix?
First of all, looking at this patient, lots of compassion. We see that he's an unsheltered person and that he has polysubstance use. Now, for me, summarizing, the first thing that I would situate myself in is withdrawal, specifically from alcohol. Of course, I'm not here to judge, but it's very important to know, like, again, my approach would be like this person regularly uses, right? So we have to be taking care of the next people with alcohol withdrawal syndrome. Something like be very careful with withdrawal seizures, specifically in alcohol. Look for this person's really anxious. As you're painting this picture, Laura, I see him as a very anxious. It maybe look for signs of tremor. Look for if he's dizzy, vomiting. Try to identify these signs and symptoms early. Because this is where we come in and try to do not damage control, but give him the proper treatment. Right?
I agree with you. I think withdrawal is going to be something to pay attention to. My advice is, as you're trying to figure out substance on versus substance off, meaning the patient is intoxicated versus withdrawing from something, there are many instances where substance withdrawal can be lethal, including alcohol withdrawal. But the time to death or lethality is often on the order of hours or days. In stark contrast, substance intoxication or being on board is often, can be, not as often, can be lethal on the order of seconds to minutes. So as you try to visualize the person in front of you, I think that most of us will worry about withdrawal after we've focused on substance on. So, but let me, I'm trying to pretend that we're taking care of this patient together. So yeah, take a look at that HPI one more time and tell me what would be the primary problem that you want to work on together in the ER from what you see in the HPI.
Since he already has COPD, I would definitely look into his oxygen levels.
Exactly. And you see that it's 85% on BiPAP, right? So when you see hypoxemia in this scenario, what are some diagnostic thoughts crossing your mind?
Well, for me, now situating myself on his respiratory issues, for lack of a better word, I will think he has exposure to heroin, to opioids. So I'm thinking I will definitely look at his oxygen levels, at his respiratory rate, and tackle that part. Like that's basically thinking about that. So I think that's my first thought. Like try to see if there's any exacerbation of his COPD.
Excellent.
because I think it's very easy
Yeah.
to lose the whole picture when we hear, oh, this patient uses. So
Yep.
I noticed that. Thank you for letting me, helping me catch my anchoring on his use. He's a COPD patient.
Yeah.
He might have an exacerbation.
I think that you're right. We have to take the hypoxemia and say, is it related to COPD?
Exactly.
And generate a differential diagnosis based on that, which you did very well. And then you also use the fact that he has been using fentanyl and alcohol to help make all the possibilities.
Mhm.
So hypoxemia in a patient with COPD is often the result of a COPD exacerbation, but can be the result of many other things. The most important cause is the most important cause to rule out is a pneumothorax from COPD.
Yeah.
Let me ask you, what hypotheses come to mind as possibilities in a patient who's hypoxemic with fentanyl and alcohol use?
First, like right now, I just had a light bulb moment. This
Yeah.
person also has a prior history of fall. So maybe he had been in bed, I'm guessing, and he has previous use of fentanyl, COPD. I'm thinking aspiration. Could this be
Excellent.
an
Excellent.
aspiration process? Like
Excellent.
now, if the patient, I'm going to do a little shout out right now. If the patient is stable and I can
Mhm.
grab the POCUS and see what's in his fentanyl, I will be very, very happy because now that
Excellent.
has shown us
Excellent.
how to like look for signs of
Yeah.
pneumonia or any other issue, right?
Excellent. Superb. Yeah, I think that that's outstanding. So we'll just go back to the right now. What we're trying to fix right now is that the patient seems to be awake, but oxygenation is their problem. And so we're toggling between what's the deal with the altered mental status. And for that, you already said what we're going to do. We're going to get a finger stick glucose. We're going to proceed down that pathway. The hypoxemia is more pressing now because it's a really bad hypoxemia despite BiPAP. And the hypotheses from COPD, the most morbid one right now is a pneumothorax, which POCUS will help us figure out. And the second, more likely hypothesis is that the patient has aspiration potentially from the fentanyl or alcohol. Just for teaching, the reason that actually as you know, I don't usually ask for details from the case presenters, but here, if the patient had received naloxone or Narcan, then the possibility of non-cardiogenic pulmonary edema would be at play. There's a small risk of patients getting pulmonary edema from naloxone, and it's an interesting a pathophysiological principle, but one for you to keep in your back pocket when a patient gets sicker from a respiratory perspective with naloxone. But I know that there's 6 aliquots, so why don't we get some more information, but really, really good job on recognizing the hypoxemia and keeping both the COPD and the fentanyl and alcohol use as our inlets to diagnostic clues. All right, Laura, what do you have next?
I love your discussion. I just want to make a correction. It was 85 before BiPAP. Now it is 98. So we're going to go to the exam.
my blood pressure just relaxed a little bit. I'm glad to hear that. All right, let's get information.
Yeah. So the temperature is 38 Celsius, respiratory rate 16, pulse rate 97. His saturation is 98 on BiPAP. So for the general, he was confused and agitated, but redirectable. He had yellowish skin and overall poor hygiene. For the HENT, he had icteric sclerae, clear conjunctiva, dry oral mucosa with poor dentition, and right pupil with evidence of traumatic mydriasis. For the respiratory, he had diffuse crackles bilaterally, and for the abdomen was soft, non-tender, non-distended with bow sounds. For the extremities, he had no peripheral edema, no tenderness, had reticular red blue discoloration in bilateral lower extremities, and bilateral plantar areas were of the feet were covered in dirt. And for the neuro exam, he was confused, but the strength was preserved bilaterally and in the upper and lower extremities. Cranial nerves 2 to 12 were grossly intact, and there were no focal deficits. And I'll also give you some labs right now. So his sodium was 139, glucose 197, Potassium 3.5, chloride 107, bicarbonate 19.9, BUN 124, creatinine 4.33. Am I going too fast? Is it okay?
I don't know how he's keeping up with you, but he is.
Okay, awesome.
Yeah. It's amazing.
Anion gap 12, albumin 2.4, total protein 4.4, calcium 8, alk phos 134, AST 277, ALT 218, total bilirubin 5.3 with direct bilirubin 4.4, GGT 86, lipase 161, CPK 2192, VBG, I'm sorry, I'm not sure if this is how you say it, 7.40 over 36. Is this how you say it?
Yeah, I think what you're saying is that the pH is 7.46 and the PCO2 is, what was it? What was the number again? 36?
7.40 and like slash
Yeah.
36.
Yeah,
Okay.
the pH is 7.40, excuse me, and the PCO2 is 36.
Okay. White blood count 12.88. Hemoglobin 9.8. Hematocrit 29.6. MCV 87.8. Platelets 13. I also have ENR 1. PT and PTT were normal. Reticulocyte index 0.1. LDH 1003, fibrinogen was normal, D-dimer 1.92, and haptoglobin was normal. I'm sorry for a lot of data, but that's the end of the other question.
Yes, I don't think I've ever experienced VMR-induced vertigo, but I think I'm experiencing
It
a lot
is,
of,
it is
yeah,
intense.
it
Now
is
I'm
intense, isn't it?
wondering where do we start?
Can I share with you a piece of advice
Okay.
that comes from real life?
Mhm.
Whenever you're in a situation like this and you have a lot of data, the temptation is to start to synthesize it. But I think that that might be a more effective thing to do once we list all the problems we think that are important right now. So let's literally try to restrict ourselves to no other thoughts for the next minute other than making a list of the things that are important. So what's your list?
Perfect. So the first thing first, jaundice. This person is jaundice. This person, okay, he's hypoxemia corrected with BiPAP, so I can put that in like back.
Yeah.
We have a confused patient. We have this particular blue discoloration, although that could be not very important, but
Yeah.
we have high white blood cells.
Mm-hmm.
He has anemia. He
Mm-hmm.
has low platelets, high LDH.
Mm-hmm.
He has his labs are showing us that has hepatocellular injury because he has high AST and ALT.
Mm-hmm.
But he also has hyperbilirubinemia, the direct one, that it's telling me that and high GGT, which I'm thinking, could this be a sign of cholestasis? So those are, and high creatinine. I remember like reading it from 0.3. So
You're running out of fingers, yes.
I know I'm gonna use my foot too. That's why I'm thinking that this is a lot. And now the lipase is also high, if I'm not
Yeah.
wrong. So I am thinking this is something systemic. Could this be a like a
Yeah. Before you, I want to share some advice, but now you're starting to solve it, right? But
yeah?
now the next step, actually, so you made your list.
Mhm.
Now you have to realize that the human brain has limitations. It cannot do all these things. So what's the next step? The next step is to do what you started to do. You first make your list, and you already started to be like, I don't need to explain this right now. So now take that list and only just don't solve it yet. We have to show how to make this problem more digestible before we digest it. So now that you've started your list, now I want to ask you a harder question. The hardest will be how to solve it, but a slightly harder question will be, what do you think is your priority to solve now? Just list-wise. What is really important to you?
Okay, now that
Take your time.
he's a little bit tachypneic, what would be the first I will tackle?
Not necessarily the first, but let's say top 3.
Top 3, I would first of all put this patient on, and every attending person looking, help colleague here looking, I'm thinking of putting him on empiric antibiotics.
Oh, no, sorry. I meant, what is your top 3 abnormalities that you're...
Top 3.
Yeah.
Okay, so he's creatinine.
Yeah, I
Like
agree.
that liver is suffering. That the kidney is suffering.
Yep.
That
I agree.
that LDH is too high.
Yes.
That those kinds of levels make me think of something malignant.
Yep. And one more. You only get one more. Choose
I
wisely.
know. For me, it would be the I'm torn between the white blood cells or the LFTs.
I have a similar tension. Can I tell you my top 3 list to help us proceed to
Okay.
begin?
Yeah, I will definitely like to know it.
It's exactly yours, but I chose the liver. And that's why. How many times have you seen a white count of 12 mean of no significance in a patient like this?
That makes
So
sense.
here's what I did when I heard this. I was like, we have to figure out the kidney. The B1 is 124. We have to figure out the liver because bilirubin is usually very, very specific and often a clue to the case. And then the hematological fingerprint of this case is very strong. And what I did was I took anemia, thrombocytopenia, and LDH and just put them under one organ. Just like we said, jaundice liver, creatinine kidney, I called that stuff hematologic. The lipase is non-specific, especially in patients with AKI. The white count is non-specific because we already know this person is inflamed because he's febrile. Altered mental status is very often the sequelae of something else rather than the primary driver. So I agree with your list. The core problems here are jaundice, acute kidney injury, and anemia, thrombocytopenia, and a high LDH. So let's just tackle one by one. What do you think are the most morbid causes of anemia, thrombocytopenia, and high LDH? What does that take you?
That my liver is right. That is the first thing. I'm thinking that we have to help this patient's liver because one thing is that if we don't have the proteins, meaning the platelet, the liver creates platelets, the liver creates this detoxified organism. Like if we don't take care of this liver right now, this patient will like plummet.
Agreed.
So
what if the smear shows schistocytes? What would that be?
I'm thinking of microhepatic hemolysis at DIC. I'm thinking those kinds of things.
Yes.
Because we still don't have a PT, but that will give us a lot of information.
Excellent. Awesome. I love that. What do you think about the AKI?
AKI, that even though we don't have a baseline, this level of creatinine is also showing us that systemically this patient is like getting into like the red zone. Like we have to start taking care, like fluids, be very careful with fluids, because it doesn't mean that, oh, because the creatinine is too high, I'm going to like put all the like saline and stuff. We have to be very careful while rehydrating a patient. And one thing I have been wondering right now is this patient could have like, we could send a viral panel after we stabilize him and see what is the root cause? Why is his liver? Of course, he has previous use, but we cannot put everything in a square, like in a box.
Yeah, I agree with you. Absolutely superb thoughts. I love how you prioritize the top 3 things. I think this patient would be receiving a lot of supportive care, namely fluids. here's my take. I think that the LDH being this high tells us there's cellular destruction happening. And the question is, which cells are being destroyed? And when you see that the hemoglobin is low and the platelet counts are low, the default assumption should be that the patient is having those cells be destroyed. But that hypothesis is put into question because the signature of hemolysis otherwise isn't there. The haptoglobin is normal, and the patient has not indirect, but actually direct hyperbilirubinemia, calling to question whether the LDH is from hemolysis. But it's such a morbid hypothesis that a peripheral smear will be very, very telling. We have many causes of an AKI here. We definitely have a component of prerenal, but the CK might have been higher. For a CK to cause kidney injury, the CK usually has to be over 5,000. It could have been higher before and now has lowered as part of the improvement of the process. And the LDH may represent muscle damage that was more prominent before but started to improve. So I agree with you. I think the next steps in this patient are to understand not the quantitative aspects of the hematological system, but the qualitative aspects of it, which is what does it look like under a peripheral smear? And I think the next step is, as you said, send off infectious testing for viral hepatitis. But we have to look at this liver and try to localize. Is this intrahepatic jaundice for which alcohol would be on the hook? Or is this patient having biliary stone disease with multi-organ injury as a result of cholangitis, given the fever and the white count? So we have a lot left to discuss. So I'll pass the mic to Laura to tell us a little bit more.
Not sure if you guys are having fun, but I am having like the time of my life. I love watching you guys discuss. And I felt like I just it was a shower of information and you just dissected it brilliantly. Okay, so I'll give you some cultures and some imaging and yeah. So I have UA. The urine was turbid. It had 2 plus heme, 1 plus protein, 2 plus glucose, negative for ketones and nitrites. Glucose esterase was 250, RBC 8, WBC 26. Urine culture, blood culture, and sputum culture were negative. MRSA negative. And the toxins in the urine, it was positive only for methadone and BCB. I also have, where is it? I was looking for okay, I have the CT of the head. It was negative for acute intracranial pathology, but positive for chronic involutional changes of the brain with chronic encephalomalacia in the frontal lobes. And there was this old fracture in the right superior orbital rim and right frontal sinus. The CT of the abdomen showed no obvious acute abnormality, but it was limited due to motion artifacts. And in the chest, there was emphysema and infiltrates in bilateral lungs. And there was an abdomen ultrasound that showed sludge within the gallbladder, and there was no cholelithiasis, or cholecystitis, but there was a mildly enlarged liver, and the pancreas was unremarkable. I will share my screen with you for you guys to see the images. 1 second. Okay, 1 second, and I have no idea how to do that anymore.
That's okay, no problem.
Okay, it's big and green. Yes. Here. Can you see it?
It looks like it's yep, we see it now.
I can make it big. Yeah.
What do you think?
And
yeah. Oh, go ahead.
oh, that's the end. Yeah.
Okay. All right. Terrific. Perfect. So yes, you just got a lot of information. What did it do for you?
I do. I am thinking that, first of all, I'm seeing all this diffuse. Yeah, can you make it a little bit bigger, please? I see all this diffuse, like ground, looks like ground gas opacities on the nodularities. Like these look like nodularities actually, like diffuse. If I'm seeing right. And then one thing is, of course, we have this like barrel chest. That's part of the COPD. We have this like um I'm not sure if what I'm seeing on the upper lobe. I'm thinking one, this could be an like an infection exacerbating his COPD. And I would definitely want to do a BAL, a bowel,
Yeah.
because this very well looks like nodules. This could be cysts. There are like atelectasis. It's very like
Mhm.
this is a very sick patient.
Yeah, I agree with you. I think what you're seeing is a combination of consolidation, which is what you said.
Yes.
And then the cystic things are absolutely right. So those are probably emphysematous blebs. That's
Mhm.
the radiographic imprint of the COPD. But yeah, this patient obviously has radiographic evidence of emphysema, and then has I would say the predominant abnormality that I see are dependent consolidations with yeah. It's hard to make much progress on this. I think that you're right. In a patient with fever and these infiltrates and infection is probably the most important thing, though aspiration from what you mentioned earlier is really important. Um, Maybe we can look at the rest of the data to see what progress we can make. We had the abdominal imaging in the setting of AKI, and in the setting of jaundice, we had the abdominal imaging be unrevealing. That
Yeah.
may at first glance be a little disappointing, but how does it help you?
It will make me think that this is more okay. I had a question, but I didn't do like that with that GGT level that we had of 86.
Huh?
Could we think about this could be cholestasis, and we could situate our main issue, the liver, being
Yes.
liver. Um, because of course we haven't got a viral panel. I hope we do have one.
Yeah.
But I'm thinking if there is a there's an abdominal process, like we have kidney issues, we have liver issues, we have somehow like pancreatic issues, and there is a negative image. I'm thinking more something like viral. That's and I'm not trying to anchor an ID, even though I really like it, but that's one of my first thoughts.
I think that you're right. Maybe Shreyas, you can share the screen again so we can look at the data. But when you're trying to figure out where the lesion is, not necessarily what it is. In jaundice, you're trying to figure out, is the problem in the liver itself, or is it in the extrahepatic biliary tree? And um, when you take a picture and you see that there's nothing radiographically wrong with the common bile duct or the cystic duct, the probability that the disease is inside the liver is much, much higher, or intrahepatic. And the same can be said of the kidney, is when you take a picture of the kidney and you see that the ureter isn't dilated or obstructed, the possibility of postrenal disease is very, very low. So I think we can summarize by saying that now we have intrinsic liver disease that is intraparenchymal. We have intrinsic renal disease with a component probably of pre-renal. And I agree with you, in a patient who has an infectious syndrome, a fever, and these abnormalities, we have to start to say, well, what infections cause this? And I think testing for viral hepatitis, like you said, a long, long time ago, is really, really important. But I think that preparing for unusual infections is important because this patient has an unusual fingerprint. And that fingerprint is that the patient has deep thrombocytopenia and AKI. So I know I can feel your anticipation, your nerdiness. But remember the goal of this. The goal of this is not to get the answer, it's to explain your thinking. So let me ask you this. What infections do you associate with having a deep, when you think infection plus thrombocytopenia, what infections cross your mind?
And yeah, so I'm obviously assuming that this patient is in Brazil because Laura is in
Yeah.
Brazil. The
Yeah.
first thing that I think about is dengue
Uh-huh. Excellent.
because that affects us.
Yeah.
Platelets, we can have hemorrhagic dengue. We can
Excellent.
have and other arboviruses such as yellow fever.
Excellent.
Um, I wouldn't say that this could be chikungunya Zika because we don't have rash, we don't have
Yeah.
like joint
Excellent.
pain, but those are the first ones that I will think.
Mm.
Of course, aside from other tropical diseases, but those are the first two that
Excellent.
come into my mind.
Excellent. Oh, that is so in terms of viral causes of thrombocytopenia, there are two mechanisms. There's viral unleashing ITP, of which there are many causes, including the mononucleosis viruses, and HIV. But if you're doing virus-inducing thrombocytopenia through direct mechanisms, you're absolutely right that the arboviruses are the lead cause of that. Now, a harder question. What about bacterial causes of deep thrombocytopenia?
The first one, rickettsia.
Yes, excellent.
Rickettsia and the Bartonella,
Excellent.
Salmonella, what
Yep.
else?
Ella, over and over.
All the Ellas. All the
Excellent.
Ellas can cause hemolysis.
Yep.
And on parasites, like the will be also malaria,
Yep.
babesiosis.
Excellent.
So
There's one more I want to add to your list, and I know you know it in
uh,
terms of bacteria. So let me give you a hint. Imagine if Laura accidentally told us this patient was swimming in fresh water and has jaundice, AKI. What's that?
leptospira,
Excellent. Perfect.
like murky water, leptospira all the time.
So I think what do we have to do in real life in this situation right now? And yes, I saw somebody in the chat say hantavirus. Absolutely right. That's a very important thought to have. By the way, just for the completeness, the viral causes of deep thrombocytopenia, there's three of them, all the arboviruses, measles, and hantavirus. Anyway, this patient, yeah, as you said it early on, we should probably give them antibiotics. And I think that the antibiotics that's necessary here are probably to cover the lungs. But you might start to think, with all the unusual infections you're thinking about that's caused deep thrombocytopenia, is what are the ones that are treatable? And I think here you might give ceftriaxone for the possibility of leptospirosis, and you might give doxycycline for the possibility of rickettsia. I think all that I want to highlight here is that this patient, you can see how what Yas said early on is panning out. She said, don't anchor on the substance use. And of course, that all of this could be in large part because of the alcohol use getting the liver down and the CK from being down causing kidney issues. It could all be related to this. But I think you have to start to think well beyond that with a fever, a white count, and this pattern of disease. But just to be honest, if base rate were the driver of this case, most patients with significant alcohol use may have alcohol-induced liver dysfunction and alcohol-induced intoxication followed by prolonged immobilization resulting in CK-induced kidney disease. What's the clue? All these things will slowly get better with supportive care, especially the kidney. If it does not, it's a trigger to think beyond that. And here, the triggers to think beyond that are the fever, the white count, and for me, the height of the LDH and the depth of the thrombocytopenia, which are unusual to this degree in a patient with alcohol use. All right, Laura, tell us more.
I loved seeing Ya's faces light up when she thought of infectious causes. She was like, oh, finally. Okay, I have more labs for you. So now I have the peripheral blood smear. It was negative for schistocytes, and the ferritin was 292. Total iron binding capacity was 205, and transferrin saturation of 7, B12 584. And ANA, P ANCA, C ANCA, anti-GBM, or all negative. Direct antiglobulin test was positive. HSV 1 and 2 negative. CMV, IgG was positive, but IgM negative. Epstein-Barr, IgG positive, IgM negative. HIV, syphilis, and hepatitis B negative, hepatitis C antibodies positive, and viral load of 25 million. That's it. And after that is going to be the final aliquot.
And the final aliquot will give the diagnosis, or the final aliquot with a, it will? Okay. So we have to come up with a diagnosis now, huh? All right, you got it. Yes, you asked for viral serologies centuries ago. Here you are. What do you think?
First of all, correct me if I'm wrong. Having the IgG positive means that we have had this like in around 2-3 weeks, the infection, and we only get the IgM after like just that's like the acute one, right? So maybe this person only like once in his life had these ones. So I wouldn't like focus on this one. The one that is like there blinking is a Hep C. And what happens with FC is that this virus can cause, is one of the etiologies of hepatocellular carcinoma. It can also cause cryoglobulinemia, can give us like this microangiopathic hemolysis. So I'm thinking this person, honestly, I'm not very familiar with the treatment for hepatitis C, but with this patient, like this is a question like open for everyone, for you, Rabih, like would you start a treatment with antivirals for Hep C if we have a positive viral load of 25 million?
Yeah, I think that that's the crux of this case. The question that I think the team would be taking care of now is to say, does everything that we see here, is that explained by hepatitis C? And I think you wisely emphasized that the manifestations of hepatitis C are acute liver injury or failure. Now in the United States, the most common cause of acute liver injury of the viral infections is hepatitis C. Even though only a fraction of patients get acute symptoms, the sheer burden of hepatitis C in the United States has made it the leading cause of acute liver injury. Here we see a hint of liver nodularity on the ultrasound, hinting that the patient might have early cirrhosis from this hepatitis C. But you also emphasized how you can have extrahepatic manifestations of hepatitis C that affect the kidney. And now you might look back and bring something to the forefront that you put behind you, which is the discoloration on the legs. And wonder, in a patient with hepatitis C who has liver injury and kidney injury, as you alluded to, could they have cryoglobulonemic manifestations? And so now the skin, which was previously in the background, suddenly becomes in the foreground. And so the mechanism for the thrombocytopenia, the deep thrombocytopenia here might be in the category that we talked about earlier, which is, remember, we said viral direct, but viral indirect. And on the list of viruses, viral induced ITP is hepatitis C. So I think you're right. The actionable hypothesis from this information is to reflect on the extrahepatic manifestations of hepatitis C and to wonder if the patient has cryoglobulinemia. And the simple test for cryoglobulinemia isn't to test the cryoglobulins, it's to get complements. Cryoglobulins are very, very hard to test because you have to keep them warm until they get to the lab. And so, yeah, the cryoglobulinemia testing is complicated because the test is inaccurate, but also because 40% of patients with hepatitis C will have cryoglobulins that are present but not causing symptoms. And so the way you prove that the patient has cryo-induced disease is biopsy. You'll see the cryoprecipitate on the skin, but actually through seeing activation of the complement cascade with a very low C4 being characteristic and also having a positive rheumatoid factor. So I'm right there with you. I think I would definitely pursue the possibility of cryoglobulinemic vasculitis in this patient. Where is your head at?
After, like, I was honestly, after you were talking about cryoglobulinemia, I was thinking Hep C can also cause secondary hemochromatosis, because that blue discoloration was like, oh, blue discoloration, like grayish, very like broad. But I saw the ferritin and I was like, okay, no, that thought went out of the window.
Yeah.
But yeah, that will be my first thought, like looking for C3, C4, and to see if this could be cryoglobulinemia too, because Hep C it's a very nasty virus, honestly.
Yeah, I completely agree. I'm going to show you all a visual to help guide where this conversation could go. One moment, please. So, oh, I can't find it. I'm sorry. One more second. Yeah, here it is. I found it. Sorry for the delay. So, I think we've, with more and more time, centered our conversation around liver plus kidney issues. And I think we proved that the kidney issue is intrinsic renal by the fact that it persists with fluid resuscitation and there's no obstruction. So you can see that the differential diagnosis isn't very many things. If we assume that this is the crux of the case, and when we find a positivity for hepatitis C, I think we have to pursue that hypothesis. Yeah, the biggest piece of advice is if you're thinking cryo, which many people might be thinking in this case, the cryo testing is highly imperfect. It can be falsely negative because it wasn't sent right to the lab. And it can be falsely positive and unrelated because anyone with Hep C has a 40% chance of having cryos be there for no reason. So you have to try to prove that they're causing consequences. And the way you do that is you can get a biopsy to see them precipitate. They show up on PS staining of the skin biopsy, or you see that they're activating complement and rheumatoid factor. Alrighty, Laura, tell us what you all found.
I don't know if like during the presentation you guys noticed my face with everything that you were saying, and I felt like I was giving clues like whenever I smiled or something like that, but I'm not sure if you noticed it. So yeah, that was amazing. I'll tell you a little bit about the hospital course. It was a 7-day hospital course, and it is important to say that they repeated the LDH and it came back normal. For the repeated version. And after like 3 to 4 days, the patient was intubated and admitted to the MICU for acute hypoxic respiratory failure. The ICU course was complicated by persistent fever, and he had high probability for PE and hyperammonemia and one episode of blood-tinged stool. It was performed an MRCP and did not show biliary obstruction. And the ID suggested that they collected leptospirosis tests. IgM came back positive, and they started doxycycline and ceftriaxone, waiting for the PCR results, urine PCR, which also came back positive. So the final diagnosis was actually leptospirosis. And the patient improved, the mental status improved, LFTs and renal function, and he was discharged with recommended outpatient treatment for HCV. And it was amazing to watch your discussion. I just want to say something, that this case wasn't actually mine. Rabih gave me this case. So it didn't actually happen in Brazil. It happened in the US. And this is very like the nice point to focus on, because in the United States, it is really rare to have leptospirosis, but in my country, it is actually like common. It is something that you hear a lot here. And I want to know what your thoughts are, and yeah, if you like that.
This is amazing. I'm thinking now, Ravi, it makes sense. The reticular blue discoloration, there is a severe like leptospirosis called whale disease. And that is called the hemorrhagic diathesis, where the patient has like purpuric like hematomas, like like all this, like the patient starts like with hemoptysis. So I'm thinking, and of course he had kidney, liver, and fever. So yeah, like those three. So it's very interesting. Now I'm wondering, where did he get leptospirosis from? Although this person is unsheltered, so like honestly, a lot of infections are like more common on them, on patients that have these kinds of like exposures. So I'm wondering that aside from medical treatment, if like we should like push policies so to prevent this unsheltered issues on population. So that's just a thought, because this is a really intense case.
Rabih, you're muted.
Oh, sorry. Thank you, Laura. I think that I think the journey that you took us on was a very, very complicated one. But ultimately, I think that it goes to show you the power of channeling your energy and your thoughts into first trying to make a problem list, and then trying to order that problem list, and help you figure out like what are the key problems here. And if you go back and you're like, what causes liver, kidney, and hematological issues? You can start to refine your thinking, but the biggest clue here was, if you look back in this case and like what made us think of it, really it's just a very, very, you have a liver plus kidney schema, which we showed you, and then what are the infectious causes of a deep thrombocytopenia? And leptospirosis is definitely on that list. And very, very characteristic presentation is disproportionate cholestasis and kidney injury, along with the CK elevation and pulmonary hemorrhage. So this case is a very, very classic presentation of it, but it's so hard to sniff out leptospirosis when there's so many alternative hypotheses that can affect those organs, especially the alcohol use here. But I think for me, if you say the platelet count is 13, that needs an explanation that doesn't often fit in all the usual things we do related to alcohol use. And so if you have a rich approach to thrombocytopenia, that'll help you spot leptospirosis. The other massive clue here is that the kidney injury is of an interstitial pattern, and the interstitial pattern is evident by the prominent pyuria, suggestive of interstitial nephritis, and the potassium wasting. So if you look at the patient's creatinine of 4, the potassium is often much higher. So interstitial nephritis, cholestasis, thrombocytopenia, and lung disease is very suggestive of leptospirosis. And yes, unfortunately, there's a lot of leptospirosis in the United States. Most of it is in Hawaii. Most folks go and have a great time in Hawaii and unfortunately come back with leptospirosis. But yeah, there's a lot of, in urban areas, a lot of exposure to rodent urine. And Baltimore actually had an outbreak of leptospirosis. So I wonder if, I wonder if that's the source. But I think it's a worldwide infection. Basically, you can't not think of lepto.
Wait, stop giving information. I have an infographic for that.
Oh, okay. All right, you got it. Mic is yours, Laura, for the infographic. And by the way, I should apologize. No problem at all. No, please do it. I have to step away anyway. I have to leave now to make it on time for work, so I'll miss your infographic and Tansu's teaching points. But Tansu, I made you co-host. I made you host. So please feel free to enjoy this journey again together. Just make sure to end the meeting when you're done. All right, Laura, mic is yours, and I will see you all later. Thank you for an amazing hour. I really, really enjoyed it.
Thank you, Rabih. Can you guys see the screen? Yes, someone?
Yes.
Okay.
We can see this.
Yeah, so it's gonna be really quick, I swear. We'll talk about leptospirosis. How do I take this out of here? How do I move this? Oh, okay. Let's start with the leptospira. It is a spiral-shaped, highly motile aerobic spirochete with unique question mark hook, as you can see here, this beautiful image. And as Rabih said, it is actually the most widespread zoonosis in the world. And you might think like, we don't hear about that often, And it's because most cases are mild and self-limited or asymptomatic. And you can see the little rats here. They're in the endemic areas, which are South and Southeast Asia, Oceania, Caribbean, Sub-Saharan Africa, and Latin America, where I live. And for the risk factors, you have to think of water, as Rabih said, because the organism is shed in the urine of mammals, especially rodents. So you have a little rat here too. And so occupational exposures such as farmers, recreational activities like canoeing, and household exposure, low socioeconomic status, like in our patient, and travel to endemic areas. And it should, the person should have like a wound, or the water should be in contact with some mucus in order for the leptospira to get in the organism. And there are two main presentations of the illness. So there is the anecteric presentation and the icteric. The anecteric is more happens more often. As you can see, this square is a little taller than the yellow one, and it has two phases. The acute phase, which is a combination of acute febrile bacteremia and conjunctival hyperemia. There is a period of improvement, and then there is the immune phase with fever, headache, myalgia, aseptic meningitis, and uveitis. And there is the icteric presentation, which is the one we just saw, that is more severe, and it is associated with mortality rates of 5 to 15%. Some people talked in the chat of the Wills disease. So it's fever, jaundice, and renal failure. The patient also presents with pulmonary hemorrhage with ARDS. They could also present with myocarditis and rhabdomyolysis. And I wanted to highlight this red eye here, because if the patient has conjunctival hyperemia, it is a big clue to leptospirosis. Our patient didn't have that, but just to keep that in mind. And yeah, that's what I wanted to share with you guys. I hope you enjoyed it. I had a lot of fun. Thank you, Yas. It was amazing, your discussion, and I can't wait to hear the teaching points.
Well, thank you so much for the great case, Laura, and great discussion, Yas, as always. So we had a 63-year-old male who came to the ER with unresponsiveness, and we were thinking if we can translate unresponsiveness to altered mental status, and in that case, we prioritize treatment and management over diagnosis. And first we do the ABCDE survey, checking the red flags, correct the correctable causes such as hypoglycemia and opioid use, overdose. And so in an unresponsive state, we think about directly neurologic and cardiovascular catastrophes, and cardiovascular problems are our priority. So to assess if the patient is having unresponsiveness because of a cardiovascular problem, we check if the patient is perfusing. And one of the signs that shows us that the patient is perfusing is breathing. If there is spontaneous breathing, the patient likely have a pulse, and if not, we need to activate code blue. And in the case of hypoxemia, since this patient had many problems that could lead to hypoxemia, such as COPD, we have to rule out pneumothorax, and focus can be helpful here. And the patient's health-related behaviors included fentanyl and alcohol use, which increases the risk of aspiration, and naloxone use can also increase the risk of pulmonary edema. In polysubstance use, we have both issues with substance on and off. Both can be lethal, but withdrawal is lethal in hours to days. Intoxication is lethal in seconds to minutes. So the front seat is intoxication. It takes the front seat. We have to first rule out substance on phenomena, which is intoxication. And then whenever we have a long list of problems, we first have to prioritize what is the most important problem and make the long list of problems digestible. Here we identified the core problems being AKI, and we thought that the AKI was intrinsic here because there was no correction with fluids of creatinine, and there was pyuria and potassium wasting out of proportion to the creatinine. And then liver is our second organ that was troubled by the clinical picture here. And with the direct bilirubinemia and jaundice and no extrahepatic signature in the imaging, we decided that there's an intrahepatic process going on. And then there was a list of hematologic abnormalities such as anemia, thrombocytopenia, high LDH, but normal haptoglobin and high creatine kinase. So we need to see not just the quantitative, but also the qualitative aspects of the heme process with a peripheral blood smear that could be helpful, but we didn't get it here. And then on the CT, we saw that there was also a lung imprint of the clinical manifestation of the disease that patient had. And then we identified the unusual fingerprint being the deep thrombocytopenia and fever. And given the patient's history of alcohol use disorder and IV drug use history, we thought that the base rate favors immobilization and liver disease as an explanation to the clinical picture we are seeing here. And since the patient had fever and deep thrombocytopenia, we thought about the infectious causes of deep thrombocytopenia, and we made a list with viral, bacterial, and parasitic causes, and concluded that we should treat the treatables with antibiotics, which could be the bacterial ones, the bacterial causes here. When we learned from Laura that the patient had extrahepatic manifestations, such as skin discoloration, and he was also HCV positive, we entertained the idea of cryoglobulinemia, but cryo testing is imperfect and we need to send it directly to the lab. That's why we don't check the cryoglobulins, we check the complements, and in cryoglobulinemia, we find low C4 count and positive RF, and skin biopsy to see the precipitates could be helpful. At the end, we found that through the ID consultation, the patient had leptospira IgM antibodies positive. Urine PCR also turned out positive for leptospira, and the treatment was started. And the whole picture of liver, kidney, hematologic abnormalities, and the lung hemorrhage made sense at the end because we found the unifying diagnosis. Thank you so much for listening. Have a nice day.
Thank you so much. Bye.
Bye.